Good morning, everybody. Welcome to our summit of 2022. We're very excited to have you here. I am Girard. I am our Vice President of Business Line Management. I am a certified risk coder, and I run our quality programs, including the differential adjusted payment program, as well as multiple other programs, including our ECQM programs, targeted investment, and many others. I also oversee our social determinants of health program and our Arizona Health Directive Registry. So today you're joining me here for our Improving Outcomes, Driving Value using Health Information Exchange Data and Value-Based Performance Contracts. So certainly a mouthful, but we're going to talk about what does that actually mean for us today. So with that, we're going to talk about what our organization's doing to adapt a value-based payment environment in order to be successful. So again, this can come in the form of contracts. It can also come in the form of special programs. Understanding how organizations are using different population health and other data, including the health information, to improve quality and earn the value-based performance measures. And then we're also going to understand the different challenges and pain points associated with moving from that fee-for-service model into that quality model and what it takes to actually be successful. So what are value-based programs or contracts? What it's doing is it is really helping to reward organizations for providing quality of care. It really gets at the quadruple aim. So are we actually improving our patient outcomes? Are we improving patient satisfaction? Are we reducing total cost of care? And at the end of that triple aim, we have that quadruple, and that's provider satisfaction. And these value-based programs are really getting at the heart of how do we solve for that particular problem and paying to incentivize those who are doing well. So some of the examples, I have these aligned from programs and contracts. So we have the quality payment program, so historically our Medicare contracts, and those are, that is up to 9% plus or minus incentive. We have various alternative payment models. So in Colorado, we have our Medicaid APM program, which is incentivizing an up to 4% increase on their payments. Additionally, in Colorado, we've been a bit spoiled with different Medicare programs as well. So we have our Primary Care First. We also have Comprehensive Primary Care Initiative. In Arizona, we also have a Medicaid program called Differential Adjusted Payment Program, or it's lovingly referred to as DAP. We also have different contract mechanisms. So you might be going through accountable care organizations, and you might be contracting with commercial payers on your own as well outside of those ACOs. So the different components of those value-based programs, they can have multiple different impacts. So we have that quality of care. And those could come in the form of different claims measurement. So if you're ED reutilization, it might be lead screenings. We also see clinical quality measures, so things like breast cancer screening, cervical cancer screening, depression screening, and follow-up. Those are all examples of performance that are being monitored every day. We also have different utilization of data. So how are you actually taking in your data, be that from the Health Information Exchange, and actually using it to drive patient care? Maybe it's identifying gaps, maybe it's just outreach for different hospital utilizations. And we also have the risk coding component. So I'm a certified risk coder. What we can do is we can actually see how high of a risk is your patient. So if we have a diabetes who's uncomplicated, they're a third of a risk of any patient with a diabetic patient with any complication, whether that's neuropathy or otherwise. So today I am grateful to have a great panel with me. So we have Dr. Franczak and Dr. Webster from Copa Health. Copa Health serves over 11,000 patients with severe mental illness. They're participating in the Targeted Investment Program and DAP programs, and they have some value-based contracts associated to that. Dr. Franczak is the Director of Population Health, and Dr. Webster is the Assistant Director of Population Health. We also have Audrey Rich-Loy. She is the Director of Program, and she is overseeing multiple different programs in Colorado. She has the alternative payment model for the Colorado Medicaid, the Comprehensive Primary Care Initiative. Though it's sunsetted, she still oversees many of the ongoing activities, and then several different value-based contracts with commercial payers. And then we have Serena Gutierrez, and she is the Vice President of Population Health at Bayless Integrated Healthcare, and they have 300 different providers. 80% of those visits happening are virtual with their patients, and that is a big shift from COVID, and that's an adaptation that we've seen. But prior to COVID, they were only doing about 5% of those visits virtually. Bayless is participating in DAP and targeted investment. So with that, I'm going to turn it over to Copa Health to talk through some of the great work that they're doing. We'll go through these slides, and then we'll open up for panel questions.
Yeah, good morning. I'm Mike Franczak. This is Jacqueline Webster. We also have a person in the audience, Derek Baker, who, if there are any complicated questions, please ask him. We are from Copa Health. We are the Population Health Department. And I think you see a pretty complicated slide. There was a great cartoon in the New Yorker many years back where the devil was interviewing somebody, and he said, "I'm looking for somebody who knows torture." And the guy said, "I know PowerPoint." And he said, "You're perfect." So I'm going to try to move through this slide very quickly. The goal, as you stated, is to talk about how we use the HIE data and other information to improve our outcomes for folks and drive value. Our data systems combine large sets of data using algorithms to identify patterns and relationships. And in order for this to happen, we have had to create a data lake or a data warehouse. Our brief presentation will talk to you about how we use that data and manipulate it to actually produce an outcome for an individual. Dr. Webster.
Thank you. So hopefully you can hear me okay. We have the artificial intelligence, assisted intelligence, and actionable intelligence that we are going to be going over. So let's start with that first one, that artificial intelligence. So at Copa Health, we use multiple sources of data to accomplish this part, and those are all listed there. The first one listed is the HIE ADT alerts and the HIE portals. This is one of our primary sources of data for our data lake. And one of the major benefits is that it does provide that real-time information. The next one you see listed are our value-based contract reports. Again, very valuable information. The drawback here a little bit is that due to claims lag, this information is delayed. Under that, we see our TIP reports. So this is an example of our value-based contract reports. And for those who don't know, that is the Targeted Investment Program, which is the program created by Access to give those financial incentives to eligible providers to develop systems for integrated care and to prepare agencies for value-based care. The main sources of data we use for that are the diabetes screenings, so A1C, and then our follow-up after hospitalization. And then the last one we see listed is our electronic medical record data. So for us, another primary source of data. It provides different sources of information that's relevant to our data lake, and that includes diagnoses, that includes procedures, lab results, dates of services, and so on. And I'll pass it back over to you.
Yeah, with respect to artificial intelligence, it is in its infancy in the behavioral health field as compared to other industries and other medical specialties. In behavioral health, we don't have blood tests, MRIs, X-rays, other quantifiable or digitized data to identify issues. So we use algorithms, some machine learning, but little or no sophisticated artificial intelligence. Not to be discouraged, though, sociologist William Cameron stated, not everything that counts can be counted, and not everything that can be counted counts. So there's a lot of data going into our data lakes, in the sense that most of it goes unused. So I refer to somewhat of our data lake as the data graveyard, because over time, much information has been stored in there but never used. But just like human intelligence, artificial intelligence, and if you gave it an artificial intelligence quotient, is based on how much information and knowledge is ingested in the data lake. HIE data alerts gives us, and some of the other data that Dr. Webster talked about, give us the who, what, when, where, but it doesn't give us the why. So once the data is in the data warehouse, we have to apply algorithms, statistical analysis, and some simulations. And most data in the warehouse, particularly claims data, is 3 to 6 months old. It's sort of like trying to drive your car looking through the rearview mirror. You're seeing what happened 6 months ago, not what happened just recently. Some HIEs don't even include behavioral health data. And that's kind of a challenge because of the bidirectional nature of physical and behavioral health and the significant comorbidity and diagnoses and reasons for admission can be very variable. The information that we have in our data lake is categorized, compared, but not cognated. That's not really a word, but I made it up. It doesn't, in other words, it doesn't think. So what we move along with in the assisted intelligence, HIE findings and the findings we get from our data lake need to be reported in a way that's easy to understand by clinicians and clinical teams. We need to separate the signal from the noise, the wheat from the chaff, the gold from the slag, so that only the right information is given to the right person in the right time for the right purpose. We are not sitting in a NASA station where we have 27 monitors. Clinicians are working with people. They need to know quickly what they need to know to give the best care. So, as Ben Franklin said, and we have this big warehouse, what good is a sundial if you keep it in the shade? So, it's very important for us to maybe extract everything we need to know out of data systems and give it to professionals. We categorize the data at the systems level and at the individual level. Dr. Webster will talk a little bit more about the systems level. But at the individual level, we use the dashboards to start a case formulation with an integrated clinical team. And what we're looking for is the why. Or as Dr. Michael Marmot, I guess he's Sir Michael Marmot, said, what we're looking for is the cause of causes. And many times what we're finding in the cause of cause are social determinant issues. And one of the interesting things I've seen is with respect to social determinant issues, all of the things we're collecting, housing stability, food, safety, all these other issues, it's not just social determinants, it's social economic determinants that are driving much of this. And when we're looking at the causes, we're finding a number of issues that need to be addressed deeper than the basic services we're providing. So what we look for is people, places, patterns. Patterns reveal preferences. Preferences reveal motives. Motives help us guide treatment. We use the 5 whys of Toyota that Toyota has used in their industry to get to the bottom why. Question, just very quickly, and I know somebody's timing us, so I can give everybody enough time. We find people going into the hospital repeatedly. And when they're going into the hospital, when we look behind it, the whys, we see that they're trying to get out of 105 degrees in Arizona. They don't trust shelters. Hospitals aren't what they used to be in the old movies. And you get a bed, you get food, you get clean clothes, and you're safe for a while. So many times people are making those choices because the options that they have available are extremely limited to them. So we also use the principles of behavioral economics. I don't know if any of you are familiar with that. There's 2 great books out on it called Nudge is one, Misbehaving is another. And economists have begun studying how people make choices. Well, if you're on Medicaid, and most of our people are served, are in the range of poverty, the choices they have available for survival are very limited. And sometimes we look down at, well, why would you go into a state hospital, or why would you go into a hospital? Well, it's perfectly rational if the choices you have are street and hospital. We also use measure and make care at the systems level.
So at the systems level, we use our dashboards to examine no-shows and engagement, readmission, and then breaking down performance and what that looks like. So no-shows are very interesting, especially when it comes to value-based care, because no-shows can pose risk to the quality of healthcare services and can lead to a loss of anticipated revenue. So we have our dashboards that provide information to us about no-show rates. And we get that by getting the appointment detail information from our EHR and exporting that information daily into our analytics app and our prediction tool. And then that analytics app provides calculations on those no-show rates, which we can then further analyze by looking at provider, location, appointment type, etc. Monitoring our no-show trends in this manner is really helpful because it provides our clinics to really tailor outreach approaches. And by doing that, we can then utilize our resources more efficiently so that way we can really meet those value-based goals. The other one that we see listed are the readmissions. The information from the HIE is extremely important for creating our dashboards related to readmissions. But similar to what Dr. Franczak was saying, the biggest piece here is taking that information from the HIE and really helping the clinicians dig deeper into the why. What is the issue that needs to be addressed here? And then I'm going to move down to that very last bullet point under the assisted intelligence piece is really drilling down that performance data, looking at not only our agency, but by our individual clinics, by digging it down into our provider level, by putting it down into our clinics and team level. And what that does is it allows us to really look at performance and workflow issues. So once we can identify that, we can target what areas, again, that need to be addressed, again, with that same goal for meeting those value-based methods.
Yeah, exactly. We have, in breaking it down, we have a couple pilots we're running. There are differences in no-show rates between providers, types of service, and we try to dig in, like, what's going on here? Is it your relationship? Do you have a more difficult panel? Is it the way you're scheduling people? And we see people that are 25% show rates. We're doing the same kind of scheduling that we do for the 85% show rates. And we keep repeating the same kind of process, getting no result. So what we're trying to do is develop better workflows based on the differences. So for example, telehealth. We had a big increase in telehealth, but when we really measured no-show for telehealth, we spotted a number of problems in telehealth, including the availability of it to some people, and we need to tailor treatment to what the person really wants in the first place. So through the integrated team process, we do what's called a case formulation, where we essentially do a root cause analysis. We present the data, and the team talks about the data, but what we find when we're talking about the data is everybody who's touching that person brings in a little bit of perspective that could not be digitized. that we are then able to focus treatment. Instead of having a treatment plan that they're working on 8 different things, let's get the one thing straight that is really the cause of causes. And so we essentially doing a root cause analysis. We are looking and finding, psychiatric instability, of course, socioeconomic conditions, homeless, couch surfing, health literacy, unable to understand the services that are available, no health activation, a substance use issue. So we're able to try to find that root cause, and then we develop a hypothesis of, okay, what do we need to do to address that cause? And we use the nudge principles of behavioral economics, which are essentially motivational interviewing, implement interventions, and then I think it's your turn.
Yeah, so I'm going to go ahead and sum up the actionable intelligence because I do realize you have 2 other people up here with us. So like Dr. Mike was saying, the main thing is to implement those interventions, right? We're using those techniques to identify it, but what we really want to do is implement it. But not only implement it, you want to be able to monitor those implementations that we're doing. So monitoring and then adjusting as necessary. And there is a variety of different ways that we can do that. PDQA, or more specifically for this process, using a PDCA, a Plan, Do, Check Act, or also known as a Plan, Do, Study Act, PDSA, because those methods really help us identify what those issues are and then solve those issues at the system level. So when we're looking at this, our main goal is really to renew, review, and revise what we are doing with this pattern of artificial intelligence, assisted intelligence, and actionable intelligence. And that way we can really refine what the problem and what that pattern is. So I don't know if you want to finish up or add anything else.
No, I think that's our process. And we've had quite a bit of success in reducing inpatient hospitalizations and ER utilizations for the population that we use this model on. And it's a high-risk population. By the way, one other point I have to make. When you're doing risk analysis, remember your contracts are 1 year. They're not 5 years, so your risk analysis has to be on immediate risk, not lifelong risk. And that's one of the things we learned in doing it, our risk analysis protocol. But thank you.
Thank you so much. With that, Audrey, I'm going to have you give an explanation about what you're doing over at San Luis Valley Health.
Thank you. Good morning, everybody. I'm Audrey Rich-Loy. I'm with San Luis Valley Health. We're a very rural, isolated region of southwestern Colorado, surrounded by mountains. If you've ever heard of the Great Sand Dunes, that's where I get to live and work. And I say that because I think in listening to the presentation with my colleagues, our system is a bit unique in that we are a medical system. We're a critical access hospital and a small regional hospital system that also includes 5 primary care locations and a multi-specialty. And then beyond that, we have integrated services such as behavioral health, patient education, and care coordination. And so really, our responsibility to our community is that we're kind of it. If you need the hospital, if you need outpatient services, you're either going to be coming to us or you're going to be traveling hours over a mountain range to seek care. And so we have to get it right. And we've been incredibly fortunate to partner with Contexture over the years to help us understand the population that we serve and the needs and make that data tell our story so that we can improve and enhance our payment options as well as be able to meet the needs that we are necessary to do so. So I copied the format of the slide that you both put together because it was so brilliant. But as you can see, I am not a PowerPoint whiz, and so I'm a little archaic in my descriptions here. But we do something very similar as described. We, of course, take in our artificial intelligence. So we have our own EMR data that we pull from. We have our variable pay, our different contracts that we pull data from. We have our Contexture data that we are able to utilize, our claims data, which as mentioned is at least 6 months old, usually longer. And then we have care management data from our different care management contracts, which are different from our quality-based contracts. So our quality-based contracts are going to come from either a commercial payer or from Medicare or Medicaid, where we're truly paid for our performance. Whereas our care management contracts in Colorado, there's a separate pool of money from Medicare and Medicaid that specifically supports us in how we're managing the care of our patients. And so we get separate data from that in the form of things like well visits, A1Cs, very similar to CQMs, but just from a different source. And so we're able to pull all of that together. Little side fun fact, we decided to bring on a brand new electronic health record right in the middle of COVID. So if you can imagine the fun we have had in trying to figure out pulling all of our old data from our old system, plus building a new system in the middle of a pandemic, it's amazing I made it today, let's just say that. So we are still in the infancy of figuring out how to pull all of those new data points into a new system together, but essentially that's our goal with our artificial intelligence. We have our assisted intelligence, which is of course our daily census. So again, keep in mind we have our hospitals and our clinics that talk to one another, so we're pretty fortunate in that way. I can't imagine what it would be like to be in an urban area where you're a clinic and you've got a zillion hospitals that you've got to try to coordinate the data points from. There are limited outside sources of data that we're having to try to collate, which is pretty lucky. It also means we're it, so there's a lot of responsibility there. But we have our hospital data along with our clinic data that comes from our daily census. We have what's called BCA, if any of you have heard of or have Meditech, that's our EMR. So we have a separate platform that we use for our business analytics that takes a lot of our data points and helps produce some really helpful reporting. We have multiple registries that we've developed that help track some of our main targeted areas that help assist in gaps in care that we need to address either at the patient level or at the population level. And then, I hate to even say this out loud because it's probably not allowed, but we do a lot of manual tracking still, so it is still death by Excel. And I would imagine we can't really get away from that yet. And then of course we have our actionable intelligence. So as I mentioned, we have our care managers. They take all of the data reports that they receive and it really guides the focus and the areas that they work on. And so there's targeted outreach that takes place. So for example, we have a heavy focus on our clinical quality measures, the risk level of our patients, so things like our HCC coding in terms of how well we document the risks of our patients, along with who our payers tell us are our high-risk patients, and then we have our own internal risking system. So all of those different risk processes tell us who our patient population is that we need to focus on. We pull reports around access. So different than our no-show rate, though I find that fascinating, we measure our third next available at more of a high-level clinic level to know if we're providing the access that meets the need of our community, and we're really evaluating the times of our services and when those services are made available to our patients. And then we are observing our utilization data from a number of different points. So we're looking at our ED utilization rates, our readmission rates, and our length of stay rates, both on the hospital side and on the clinic side. And then we're looking at our costs for all of that care. And that really helps guide the activities that we utilize and implement in our clinics. We do a lot around planned care or pre-visit planning. So our registries, along with our data that we pull in from our BCA and our external partners, helps us know what do we need to cover for that specific patient for that day. So luckily we operate under a team-based care model where we scrub charts ahead of time to look at all of those different data points to tell us for John Smith that's coming in, he's gonna need a flu shot and he hasn't had an A1C in over a year, and we better get him referred for a colorectal screen, and looks like he had a high PHQ the last time he was here, so let's make sure we follow up and see that he got in for that referral for behavioral health. In addition to that, we have several campaigns that we use this data to implement. So for example, we utilize our patient portal, like I'm sure many of you do. And based on those care gaps that we identify, we develop marketing and patient education that we then blast out through our portal services. So if it's flu season, we might do it proactively in that regard. But we also might notice that there's a particular county that's low in COVID vaccination rates. So we can specifically target our population that has the portal in that community and give them some additional education in that way. And then, of course, we have our measure dashboards. So this is where we go through probably a very similar process that you described. First, there's a ton of build that goes into it. Every contract has its own way of measuring our performance. I would say, as we're going to get into questions, that's one of the things that I find pretty dissatisfying is that how Medicare reports a measure and how Medicaid reports a measure is different than how a private insurance contract is going to report a similar measure. So a lot of work goes on with our data analytics team in terms of building the workflow just right so that it's going to pull a report that's actually meaningful. Once we have that built, of course, we're doing a ton of testing and ensuring that it's working correctly, finding some provider and team super users that are willing to test out all of the lovely clicks that we make everyone do. Then, of course, we validate all of the data to ensure that it's working the way we want it to ensure that we don't get a lot of angry providers, that they went through all this process and it's not working. So we do a lot of validation before we consider it good. So all of that takes place, and luckily we have structured our team to have resources both on the technical side as well as the quality improvement side that work together to make that possible, because our quality improvement person is able to help develop the, sort of real-time, boots-on-the-ground workflow necessary to feed into the data system. And then, of course, we're monitoring, as discussed, and seeing, does this make sense? Once the data is valid, does it actually make sense? Because it might indicate that something's broken in the system, or it might indicate that we need to do some project improvement or a PDSA to improve performance around that measure. And then we perform. And luckily, we've had some great success with this model. We have seen a significant reduction in our emergency department utilization with our Medicaid population. We were recognized nationally through our CPC Plus program for our hospital utilization and the reduction in unnecessary utilizations there. At a local level, we've seen really cool things like dental visits improving. So by all of this sort of planned care, we've been able to do some pretty amazing things for our population. And then everything runs off of PDSA, or Plan, Do, Study, Act in our organization. We really value that model of quality improvement. And so we embrace it wholeheartedly, and it really infuses all the work we do once we know the data is valid and usable. And as you can see on your screen, there's a listing of all of the different contracts that we've participated in. I like to use the analogy, and I'd probably use this again when we talk about challenges. It's really like standing on the dock and having one foot in a canoe, where the canoe keeps moving and it's really uneasy, and that dock is so comfortable and you know that it's certain, but you're not allowed to keep staying on the dock. You've got to kind of start getting into the canoe. And I know for myself, I really wish, sorry about that, I could just jump in the canoe and start paddling, but we're still in a fee-for-service world. So the reality is that all of this is taking place while still trying to meet our fee-for-service initiatives at the same time. Thank you.
Thanks, Audrey. Next up, I have Serena from Bayless. We actually don't have a slide, but I'm going to let her kind of talk through that. We had some unexpected illness, so she has graciously stepped in. But Serena, do you want to talk about Bayless?
Absolutely. Thank you. Good morning, everyone. So Bayless Integrated Health. We have been serving patients in the Maricopa County area for 40 years. So we have about 200 clinical therapists, about 40 psychiatrists, 18 primary cares, and about 8 brick and mortar buildings. We'll be moving into Tucson later in 2023. So what's unique about Bayless is today we do not have a value-based contract with our health plans. So we are in our fee-for-service model today. We do participate in the targeted investment program, where we focus on patients discharging from the hospital for a behavioral health diagnosis. We focus on those patients that need an A1C lab gap closure. We also focus on well-child visits. What really works well for us on the HIE and the data that we're receiving is really retrospective look at supplemental data, closing gaps in labs and such. Where we do see a barrier for that follow-up post-discharge for those behavioral health diagnoses is just the hospitals, the behavioral health hospitals that are actually utilizing the HIE and that secondary consent that's needed to share that discharge information. So we're really relying on the relationships that we have from the various hospitals to send us the discharge information. So I'll focus on the follow-up post-discharge a little bit. So with those relationships that we build with the hospitals, if we're notified of the patient being discharged from the hospital, we're able to get that patient a visit within 7 days, 78% of the time. So Bayless is committing to providing 72-hour access to telehealth therapy. So we're very proud of being able to offer that, pretty much unheard of, that short turnaround time to get an appointment. However, where we lack is just knowing that the patient is in the hospital or even getting discharged from the hospital. Because we do not have a value-based contract with our health plan partners, we don't have access to daily census data. So again, listening to my colleagues is what a world would look like if we were able to access that census data would really be a great initiative forward for folks like Bayless that has fee-for-service contracts today. What we really focus on is integration, really the physical health and the mental health. So we're lucky enough to have, like I said, in-house psychiatrists, primary care, and therapists that really work together. And because of that 72-hour access to care for our therapists, we are able to provide service to multitude of patients across Maricopa County. We are 80% virtual. So the majority of our patients we see are virtual. But with the onset of COVID, and I know we were all in the same boat of kind of being catapulted into the telehealth or the telemedicine world, what that I saw also created were new challenges in closing gaps for lab and radiology. So now we're really having to focus on those patients that prefer virtual and actually are requesting it now. I don't see any patients that are really forward wanting to go into the brick and mortar building. So we're having to be innovative to find out ways on how we create mobile lab radiology. How do we get those ancillary services to the patients that are working virtual today? We are also very fortunate to have our physicians board certified in lifestyle medicine. It was something that it was really nice to hear when I joined Bayless. I thought that was really supportive of our clinicians as well. What we also see as we really look into the future and going to the value-based care model is really the heavy need for change management, because we have to really understand the massive shift that will have to occur with culture, processes, technology, to really truly shift from the fee-for-service to the value-based care model. And I think change management is going to be really a big part of that. Really partnering with the HIE and the data that they have available for the medical records, very valuable. Our primary cares and their care teams and their support staff at our clinics, they actually use the HIE on a regular, which is great for acute and really understanding the whole picture of the patient's health and their ancillary partners out there in the community. What I would like to see is really the need for that immediate information, really trying to get discharge information for those hospitals to help with the follow-up post-discharge. It's just not receiving notifications from the HIE, it's receiving them timely that will really make a difference in the care delivery. Thank you.
Thanks, Serena. So we're going to be jumping into our panel questions. I am going to, we spent a little bit more time in the lead up, so we're going to spend a little bit less time on questions. But if we can just have slides back. So I'm going to have Copa Health answer this first question, but how are the various programs you participate in supporting that quadruple aim?
So I would say that the biggest way is that focus on population health that I'm seeing from the programs that we participate in is taking it away from that one-size-fits-all care and focusing more on the tailored, cost-effective interventions that's really based on our patients' risk levels. That really focuses on just reducing the cost, of healthcare, but also improving the member and the provider experiences. Another way is really driving that focus on utilizing best practices and focusing on the social determinants of health, which is so important. It gives us that drive back to looking at the whole person. It gives us that drive to look at what's happening in the members' environment outside of their doctor's offices. And again, by looking at it that way and by focusing there, that's going to lead to improving patient experience and improving the health of the population. And I'll turn it over to you to add more.
I think you've got it. Yeah.
Thank you. Audrey, how do you utilize the health information exchange to support your success in the value-based programs and contracts that you have at San Luis Valley?
I am so glad I got that question because we've been doing a ton with Contexture and with you, Lauren, specifically over the years that's helped us tremendously. One of the things that we've done is we've contracted with Contexture for a number of years to really help us in analyzing our data as it would be viewed by the payer. So taking our data and being able to put it into information that is not just from our perspective, but how are our payers seeing us, whether that's through claims data or through other methods, and then giving us feedback on how we need to be thinking strategically. So for example, we have partnered in terms of looking at not only which measures we should choose to report out on, or our HCC coding and what risk our patients are looking like. And it's really helped us in making decisions around which programs to participate in and how we need to be thinking about where our efforts are, where we're prioritizing to be optimally primed for some of those performances. So for example, we actually chose not to participate in a value-based contract recently purely because of that analysis that we were afforded. It really helped us avoid something that would have been more risk than reward. So in that regard, it's been incredibly helpful. I mean, other than that, I think it's pretty straightforward in terms of being able to push our data so that our partners in the community can receive that in a timely manner and actually implement it in terms of preparing for discharges or closing some of those care gaps. And then also being able to bring the data in and utilize it not only for the high-level strategic planning that we would do, but also to bring it to that patient level to address those care gaps on a one-on-one basis.
Thank you, Audrey. Serena, what would you say are the top challenges in implementing value-based programs and contracts?
I really think it's the mindset. It's the shift. We have been living in a fee-for-service model for decades. It's really understanding the value of true value-based care and the quality and the outcomes. And I think that just aligns from the contract to the processes to how we're paying our providers and our staff and how we're incentivizing them. So I think, again, change management is going to be a huge component of that shift and that mindset, because we were focusing just on, you're going to see as many patients as you can. You're going to bill the codes that are on our contract, and now really shifting to, well, we may not want to see somebody that may just need a refill. We may want to save those time slots for somebody that really needs to see a physician. And that, I think, is just completely different, totally different mindset than what we're thinking about today in the fee-for-service model. So it's giving our clinicians, their support staff, our senior level management team, the education to truly understand the value-based care model and the quality outcomes that will truly help reduce cost and care. Really think it's also the reporting, I believe. To mirror my colleague again, we self-report. We self-report on the Excel spreadsheets from hell as well. So, and I think it's a true necessity for us, again, having our contracts the way they are and an ability to have certain data. Our health plans do share gap lists and pursuit lists for patients that we need, but what the HIE does provide by the way of the medical records really helps us with the supplemental data to close quality gaps. Not all health plans are accepting supplemental data today, so we just had a few of our partners that we were able to close those gaps, so that definitely helps. But I think the overall challenge is really the mindset and the constant education and tying that to provider incentives.
Dr. Franczak?
Yeah, there's a couple issues with value-based contracts that can be problematic. First of all, Access has helped the provider community in developing the skill set to move into the value-based world by their TIP program. And they've been doing it for 6 years, so a lot of providers are prepared to do it. But if you're in a fee-for-service environment and also have a value-based contract, there's sort of economic dissonance, because most value-based contracts work on shared savings that are distributed if you meet a particular set of measures, while a fee-for-service model is bill what you need to bill to make it provide a need. So in one case, it's saying, well, don't bill everything because you need to save something so that you get a value-based contract or you meet a value-based measure. Secondly, sometimes value-based measures are written where you're really saving it with the MCO. The money that's saved, the MCO gets a part and you get a part as a provider. Sometimes the expectations are way beyond the national findings that NCQA HEDIS measures are. They're impossible to meet. So in some ways, it could be, there could be a thumb on the scale that makes it hard for providers to meet value-based measures.
Last question, and we'll open it up for questions from the audience. What changes in value-based programs and contracts do you anticipate in the coming years? And tagging on to that, how can the Health Information Exchange serve you now and in the future to support those additional changes coming in those programs and contracts? So if you all want to briefly answer, we can start with Copa.
So I would focus on the health equity here. So if we're looking at health equity, that means that we are providing and increasing opportunities for everyone to live their healthiest life, no matter who you are, where you live, how much money you have. But we are still seeing gaps in health and healthcare today. And those gaps are caused by barriers that are set up at all levels of society. So this is where those value-based contracts can come in and start really continuing and pushing that focus on. However, if we want to really, truly impact and increase that health equity focus, we need more and better data. So without the data, those inequities are going to continue to remain unseen. And if they're unseen, they're going to continue to remain unaddressed. So the first piece with the data and health equity, we need to be able to identify where those disparities exist. And then once that's identified, we can then direct our efforts, we can direct our resources to then address those disparities. And then the last piece of it is we need to measure. So if we're putting these efforts in place, we need to be able to measure our progress toward greater equity. And I think that's what a value-based program and the HIE data can really start to help with.
Serena.
I think the biggest barrier is it's patient engagement. It's truly what's in it for me. How am I going to get there? So what we saw earlier this year is the well child visits. It's part of the targeted investment program. 40% no-show cancellation rate. 40%. It was off the charts. We went back and we did a survey, and we surveyed 100 patients and asked them what was the barriers to this visit. So overall, it was really, I'm working during the day. You know, I can't even get away to do a telehealth visit. Okay, so that results in possibility of opening up Saturday hours, weekend hours, meeting the patient where they're at, I think is definitely the future and what we need to prepare for. Social determinants of health is always a barrier, understanding what are those barriers to that patient accessing care. And lastly, patient incentives. We need to incent our patients to close these gaps. I think that will make a huge difference.
I absolutely wholeheartedly agree that equity is going to be a prime focus in all future contracts. I also think that we're going to see more of a heavy focus on cost and probably a reduction in the importance of quality measures. I think that we'll start to see that scale down a little bit differently. And so what I anticipate is that we will be either incentivized or rewarded much more on how well we manage the cost and reduce the cost versus how well we perform on measures. This is where our work in terms of analyzing our cost and utilization has been imperative to know when is it worth taking a risk versus when is it better to step back and really build our infrastructure internally before we accept a contract, and not just accepting every contract that comes our way, but being really thoughtful in our process. I also think what would help is if everybody were all in. I think it's really hard when we have colleagues that are choosing not to participate in the HIE, and we are, and so there isn't that equitable data available. And so it is really going to require the village to come forward and say, I'm not just going to participate at the bare minimum level, but I'm going to participate at a level where I'm putting up something, but I know that the benefit and the return is worth it, and it's going to make that difference. I certainly wish that all of our contracts could have measures set the same so that when we're reporting out, it wasn't having to be varied based on the payer on how we report, and also have a bit more of an incentive or a support for hospitals in participating in the HIE, because I think that's hard to encourage that participation.
Thank you all. With that, I will open the floor for any questions that we have out in the audience.
I'm always happy to break the ice. So thinking about the foot on the boat and the foot on the dock, if you look back over the last 5 to 10 years, what has been the growth of your, percentage of your revenue that's coming from value-based contracts versus fee-for-service, maybe 10 years ago versus today? And where is that tipping point in that blend or that mix of fee-for-service versus value-based where you really can go all in?
I'm happy to speak to that. I mean, it's still a drop in the bucket compared to fee-for-service for us. So even though you saw the significant list of contracts that we have, those still do not make a mark on our fee-for-service. And so what it requires is our highest levels of leadership, remembering that that's where we're headed, so that it's built into our strategic plan, and having resources dedicated to the management of them. Some of them are very, very, very small, and then some are a bit more significant. And the way we're trying to make decisions is around, does this contract likely lend itself to where we're headed versus this short-term contract that might be for a little bit of money, but it doesn't really support our long-term strategy around where we're headed.
Yeah, in the Arizona system, I think we really weren't introduced to value-based care until a few years ago. So about half of our contracts are value-based, and they're increasing all the time. I have to agree with the lady from Alamosa that it all depends upon how you define value. If value simply is reducing cost, that's one thing. But if value is improving outcomes, people are living better and longer and enjoying their life, that's another measure. So we've got to be careful that we don't just use reducing cost as the only way to determine if we're doing a good job.
With that, is there any final question that we have? Okay. With that, I think we are wrapping for lunch. So thank you all for your time today.